Test, 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 test. Hello. What I would like to talk to you about for a few minutes today is the value that X-rays, MRIs, and other imaging studies do and don't have in managing our healthcare. So I'm going to tell you a little story. I had a patient, actually this happened more than once in the time that I've been in practice. Patient came in with back pain and pain running down their leg. Now, the typical lumbar disc problem, lumbar discs are these shock-absorbing pads that sit between the vertebrae, and they sit real close to the nerves that come out. And if we're talking about our low back, that nerve runs down and goes down the leg. So what sometimes happens, this sort of like a jelly donut, it's got this firmer outer part and a softer inner part. And every now and then it happens that the softer inner part, I don't know if we can see this here, right there, kind of squirts out from the inside, sort of like a jelly donut squirting out onto your shirt. And when it does that, it gets real close to this nerve. And since that nerve goes down the leg, it can wind up causing pain down your leg. Now, a couple of ways that we examine this is, if we take your leg, if we have you lying on your back and we raise your leg up with your knee straight in what we call a straight leg raise test, it takes this nerve and so I'm trying to get this in front of the camera. It takes this nerve and pulls it right against that disc, if you can see it, the disc as it sticks out. And so it irritates that nerve. So a typical person with a disc problem, if you lay them on their back, the person who has this going on the right side, well, they're going to have pain going down their buttock and leg on the right side. If you take that right leg with the knee straight and you lift it up, they go, ow, 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 ow. And then typically there are a couple of muscles that control their big toe that are going to be weak to touch. Their reflexes are going to be changed. There's a whole series of exam findings that we'd find in our typical disc problem. So I've got a problem. I've got a patient with pain going down their right leg, and they've got a positive straight leg raise on that side. It hurts. The other findings aren't there, but it's sort of looking like a disc. So we sent him for an MRI, and the MRI comes back showing this exact thing here on the left side, and nothing like that on the right side. Now, how do we make sense out of that? Well, the way we make sense out of that is what you saw on the MRI. And the MRI, by the way, shows this really beautifully. You can see that nerve, or that disc bulging right out. You can see it touching the nerve. It's all right there on the picture. So this person had a herniated disc on their left side. It was touching their nerve on that side, but it wasn't causing any problem whatsoever. They had a negative straight leg raise on the left side. They had no weakness in the muscles. They had no pain. They had nothing wrong on the left side. So that brings to mind a very fascinating study that was done several years ago, where they took a large group of people who had all that classic disc stuff. They had the MRI that showed the disc touching the nerve on, let's say for the sake of argument, the right side. They had the positive straight leg raise, so it increased the pain when you raised their leg up straight. They had weakness in the muscles of the toe. Their reflexes were diminished. They had the whole classic thing. But they were people who decided they didn't want surgery. And so they either managed it with chiropractic care, with physical therapy, with simply gutting it out and waiting. So after 9 months, the vast majority of these people were fine. They didn't hurt anymore. They didn't have the positive straight leg raise test. Their muscles weren't weak and their reflexes were back to normal. Everything was back to normal. And they repeated the MRIs. And guess what the MRIs looked like? They looked exactly the same as they did when they were hurting. Exactly the same. They gave both sets of MRIs to trained, experienced radiologists and said, which one is the one where they hurt? They couldn't tell because they look exactly the same. So let me tell you another little story, a little closer to home. Some of you may know that a while back I was out of work for over a month with a hurt shoulder. So I had an MRI on my shoulder. It showed a torn labrum and a partially torn part of my rotator cuff. However, the torn labrum, if a labrum hurts, is torn in the way mine was, and you hold an arm out straight like this and resist pressure trying to push it down, it pulls on that torn labrum, and the person would say, ow, ow, ow. And likewise, if the particular muscle of the rotator cuff that in my case was injured, was hurt, and I'm trying to get my arm in front of the camera, and someone puts your arm in this position and pushes down on it, that pulls on that torn part of the rotator cuff, and the person would say, ow, ow, ow. Neither of those things were the case with me. I could push up as hard as I wanted to against that first resistance and against the second one. Now, fortunately, I had seen a good orthopedist who put 2 and 2 together and realized MRI may be showing that stuff, but that ain't the problem, because if it was, those exam findings would be positive. Now, I could easily have wound up with a worse orthopedist who would have said to me, oh, we need to do surgery on your shoulder. We got to fix that torn rotator cuff. We got to stitch that torn labrum back together again. As it turns out, my shoulder is, I can't even remember which shoulder it was at this point, because it is completely and totally fine. Now, if you took another MRI, those two things would probably still be there. You'd probably still see the torn labrum. You'd probably still see the tear in the rotator cuff. There's another shorty person near and dear to me who had, in the last year, had some really significant knee pain. MRI of her knee. Torn meniscus. Oh my goodness. Got to be the problem. Except that all the tests, the orthopedic tests that stress a torn meniscus, felt fine. They didn't hurt. And there was a problem at a tendon insertion called the pes anserine tendon, the middle part of the knee, that was tender, inflamed, and when we did Graston treatment, some of you may know what Graston is if you've had it done here in the office, Grastoned her knee and gave it a little bit of time, it's now completely back to normal again. Even though, without a shred of a doubt, if we took another MRI, the meniscus tear would still be there. What's the moral of the story? The moral of the stories is that while MRI and X-ray and all imaging studies are extremely valuable in managing healthcare problems, they cannot tell the whole story. A proper diagnosis requires listening to the patient and hearing them tell you what's wrong. The way they got hurt and what they feel and how the condition has progressed, does that all point in a particular direction? Then an examination, stressing the different tissues that might be involved in producing the pain, seeing which ones hurt when you stress them, which ones don't. Then adding into that the imaging studies. Now, if all those are coming together and pointing in the same direction, you can be pretty confident of an accurate diagnosis. But if one of them's going this way, and the other one's going that way, and the other one's going like this, to rely on that picture, which is way, 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 way too commonly done, and decide that the picture is telling the whole story and acting on what is in the picture is a big, big mistake. So I hope you find that interesting and useful, and I look forward to chatting with you again sometime soon.